Okay, thank you. Hello. Okay, I seem to be live. There are 87 of you watching. We'll wait for a few more friends to join in. The timing of this class has been shifted to 11 to 12, but Professor Negi took a little extra and we gave you a 5-minute break. From tomorrow, there won't be any break, right? We'll go 10 to 11 and 11 to 12 back to back. I think this will be more convenient. This is actually in response to a request from some of you, and also because it's more efficient and probably more comfortable to finish it all in the morning session. I hope you're not sleeping in the afternoons after this. I would want that you utilize the time to revise whatever it is you learned in the morning. We are throwing a lot of new terms and new science at you, and your brains will take some time to keep up with us, to adapt to the speed. Some of you are very bright and you're probably ahead but it would be wise to spend time in revision to explore several book options so that you can settle on one where the author's style suits you. It's a pleasure to read and it's not a struggle. Take your time, then select the right author and buy the books. Okay, there are about 89 people. I think we should start. You should get, if you know your friends, you should please inform them that there is a change in timing in case they did not see the website announcement or they did not hear Professor Negi's announcement. Please get your friends to come online and attend this class. I'll just wait 1 minute more and we'll start. I'll try to finish in 40 minutes. I think it's a short topic, but there is a lot of new terms, so I'll be repeating myself. You can please pay attention and then revise it in your general anatomy textbooks. There are also online resources you can explore where excellent illustrations are available, but probably the best resources for you are the anatomy dissectors, dissection manuals, as well as the atlases, gross anatomy atlases, where regional anatomy is the approach, but still every component that we've talked about, whether as a general or a systemic approach, will also be covered. The illustrations will be rich, a lot of labeling will be there, and you should start reading them and getting used to it. Alright, so let's start. So today we'll talk about joints. To complete the musculoskeletal system, we had finished with bones as a tissue or an organ which builds up the organ system, which we call musculoskeletal system. Now normally hard things like bones and cartilages and joints, we feel uncomfortable using the word organ for them. But from the point of view of it being a complex item consisting of several different types of tissues, each of them doing their own role, but working together to bring about the objective or the function of that entire piece, makes every bone or every joint or every muscle an organ too. It wouldn't be wrong. But as in general parlance, a layperson would think of organ as something soft, and all the firm hard bits will have separate names. It does not matter. For you, the scientific concept must be established. We looked at bone. I think you all got grasped it. We looked at muscle. Today, let's look at joints. So a joint is a space, or a joint is a situation where two or more musculoskeletal, or rather fibroskeletal elements come together to allow a particular interaction or movement. But if we use movement as a criteria, then many joints are immovable. So movement is not the basic criteria. The gap between the items, there is an attachment and there is a gap. And the gap is what we are referring to as a joint. So broadly and functionally, it makes sense to divide them into movable joints and immovable joints. First, let's look at the immovable ones. Now in this illustration, there is very excellent drawing and conceptual framework, but the labeling is very small. I will repeat it a little later. You just listen to the description and the concept first. So immovable joints, largely the first variety, are all called fibrous based on the material which is intervening between the ends of the two bones. So when we have bone A and bone B, and in between the tissue is fibrous in nature, we call all of them fibrous joints. Then the way these two bones juxtapose against each other, the way that fibrous tissue is applied, and how its attachment creates or limits possible movement there. It's a little bit of geometry, three-dimensional geometry. It's a lot of mechanics, and when it comes to orthopedics, it becomes a lot of carpentry. That to re-establish a broken or a dislocated joint requires that we understand how it works in health in the first place, and then we try to replace that exact function when we repair it. So the first kind of fibrous joint, which is of the immobile category, immovable joints category, the first one everyone knows of is called a suture. The label is here. I'll think I shall. Yeah. So suture, S-U-T-U-R-E, where there is a bone A and a bone B coming together, and in between there is a layer of sutural ligament, we call it, because that ligament is providing a middle layer of fibers, a peripheral layer of fibers, which is called a cambium. I think this was there in botany also, no? Some part of a tree bark was called its cambium, if I remember right. So similar terminology is being used here. This is the outer layer covering the bone. It's called the cambial layer. Outside of that, the fibers are even thicker, denser, packed together tightly, and that's called the capsular layer. Now remember, we're using this word capsule here as a tight wrapping to the end of the bone, whereas somewhere else we will be using it as a tight wrapping to the joint space. So the term is capsule, but its meaning in its context might change a bit. Please keep that in mind. What you have to remember here is, when the immovable fibrous joint called a suture, where the bones approximate each other, there is something called a sutural ligament. In that sutural ligament, there are certain parts. Exactly at the tips of the bones, there is a cambial layer. Over and above that, there is a capsular layer. So bone A and bone B have these two layers. And then between the two capsular layers of the two separate bones, there is a middle layer of sutural ligament. Now, when you peel it off in a dissection, you may not be able to appreciate all these layers when you're doing it with your naked eye. So it has to be studied in a little more finer detail and a higher magnification. But understand that this is the architecture. This is the way a suture is put together. And wrapping it all up together outside of the capsular layer of each end of the sutural bone, is a common layer wrapping up the two bones together in continuity, which is called the uniting layer. Here, the fibers are continuous from bone A to bone B. And that's what therefore becomes the strongest part, the outside most uniting layer. Now this is seen, all of these are sections, right? They're examples, each shown in sections. So if you're looking at the full bone, it is like this. And you're looking at the cut section through it to show you that there is a gap, there is a cambial layer, there is a capsular layer, there is a middle layer, and there is a uniting layer of sutural ligament. The kinds of bones which participate in this joint are mostly dermal bones. That means they are just under the skin, and they have come, their origin or their embryology is mostly of intramembranous ossification, which we talked about in the previous classes. So you remember that one kind of fibrous immobile joint is a suture. Now to begin with, when you're a little baby, one classic example of your suture is the sutures of the skull, between the frontal bone and the parietal bone, between the parietal bone and the occipital bone, and so on and so forth. That the thin, flat, plate-like bones which form the vault of your skull or the top of your cranial cavity, they are jointed together at immobile joints called sutures. So we will see this again later. For those of you for whom English is already a tough challenge, you must remember that suture is a word we use also for the stitches we take in surgery, right? Where you take a needle and a silk thread or some material, surgical material, and we approximate in the skin or in the muscle or in the fibers underneath. We stitch together torn apart parts of the body. That activity is also called applying a suture. But that is much later, that is in your clinical postings. Right now, a suture is an immobile joint mostly between two flat bones. Another kind of joint is called a syndesmosis. This also comes under fibrous joint category, which is under the immobile joint category. So here we are seeing one middle bone, a little odd shaped, and then another one bone on one side of it and another bone on another side of it. This is the sacroiliac joints between the sacrum in the middle and the left and right ilium bones on the sides. So the gap is from here to here, right? One part of the gap seems to be filled up with some material, and another part of the gap seems to have a gap. There is a space. So this part, the front part, seems to be having a gap, and that will be filled with liquid, and that's a completely different type of joint called a synovial joint. We will look at that next. But we are referring, when we say syndesmosis, to this fibrous material which is bridging the gap between the bones, and we are calling this material an interosseous ligament. Directly between the surfaces of the two bones, there is dense fiber laid down only in one direction as a very tight sheet, which is, you can't budge it. It is so strong, and it is given in areas which might be bearing some amount of body weight, and which must make a very, very tight joint, so that the two bones which are being bound together almost move as one, or almost function as a single rod of bone rather than two separate rods of bone. So then the natural question will be, if you want it to be so strong, why don't you make the whole thing bone? Right? Why give two bones there? Right? Fill it up with bone itself. Just make it a complete osseous piece. Right? But at some point in your life's journey, you might be requiring it to be slightly movable. So there is a whole bunch of immovable joints and a whole bunch of movable joints. And there is one in-between bit, which a few joints can be called partially movable joints. So this is there in the original classification. I did not start with that because I want you to read this on your own from your textbook, and come back in the next class with the answer of how do we classify joints, the exact algorithm with which we classify joints as of today, as of our understanding of today. The hint is there will be three categories: mobile, immobile, and partially mobile. This partially mobile is where all the trick is, and that is to allow for certain activities in certain periods of life. And the sacroiliac joint, for example, needs to be a little mobile during childbirth. So in women, where the pelvis has the two sacroiliac joints, this interosseous ligament can become a little more mobile, a little softer, to allow the expansion of the pelvis for the fetal head to pass through, for the baby to be born. So this is not required in men, so that particular function may never be employed, right? So this is just an example I'm giving you to say that there are times when one type of joint can progress into another type of joint, and we will look at that in individual situations. But the concept to be remembered is, as far as we have classified it and named it, this is to the best of our understanding. We call it something, or we give it a name like a syndesmosis. It's together, and desmosis, desma is skin, right? So it's not skin actually. It's membrane. So a membrane binding together two bones is an interosseous ligament, which is there in the posterior part of the sacroiliac joints, left and right, in both genders, at all ages. But there is a possibility of a little more mobile or a little less mobile variation, depending on the use you're putting to that joint. Another example, which there is no gender differentiation, is the interosseous membrane between the radius and ulna in the upper limb, also between the tibia and fibula in the lower limb. The tibia and fibula are weight-bearing bones, so there the interosseous membrane is very, very tight, and there is actually no movement possible between them. They function like a pillar of bone. They actually, you might sometimes wonder why even bother to call them two separate names, because they function as one piece, tibiofibula, right? At least as far as that interosseous membrane joint is concerned. So tibia and fibula are joined together as three joints, and so are radius and ulna. And the radius and ulnar three joints have slightly different functions than the tibiofibular three joints. Tibiofibular are modified and oriented towards stability and weight bearing, whereas radioulnar is where you're going to do a lot of work with your forearms, wrists, and hands. So they have to permit a little more movement. For example, you remember we had talked about a pair of movements called pronation and supination. Now that is possible only in the upper limb, only in the forearm wrist region, only because of interosseous membrane mobility, to some extent, not too much. And that exquisite balance is maintained because of the nature of the material that is provided between the bones. So remember these as examples of syndesmosis. The third type of fibrous joint we're looking at is called a gomphosis. Gomphosis. IS is singular. If there are 2, 3, 4, more than one, we call them SES. The plural word is gomphosis or syndesmosis. Suture, of course, plural is, you just add an it. One suture, two sutures. Right? So coming back to gomphosis, we have the dentoalveolar joint. You have a completely different item, completely different material, organ called a tooth, which is sitting in a bony cavity in your maxilla bone and your mandible bone, in your facial skeleton. Now the way this item sits in the bone, this is not bone. The tooth and the bone are interconnecting with each other in such a way there is a kind of a partial locking in mechanism. But to be able to exact mechanical traction in the activity of chewing, this should be an immobile joint. The tooth shouldn't be loose. It has to be very tightly, strongly embedded in the jaw so that any pressure you apply to the biting surface or the chewing surface of the teeth is transmitted to the mandible and is taken by the musculature, which is going to move. It's going to move the joint against the resistance of what you're biting. Isn't it? You've probably seen on TV or in movies, people are able to pull a car with their teeth, with the rope between their teeth. So huge amount of kilogram force is able to be carried by the joints in your jaw. They're that strong, and that's possible only because we have provided something called an immobile joint over there for all your 32 teeth. And that's called a gomphosis, the dentoalveolar joint. Again, can you see this blue? There is a membranous bond or binding provided between the outermost surface of the roots of the teeth and the innermost surface of the alveolar cavity of your bone, either mandible bone or maxillary bone, where the teeth are available. We'll look at that more in detail when we come to head and neck. Remember the word, interesting word, gomphosis. Okay. Then the fourth kind of joint is called a shindylosis. I rather like this word. It's got a nice sound to it. The spelling is tricky. Please remember it. Shindylosis. The only example we know of it in the adult human skeleton is the joint between the sphenoidal bone and the vomer. The vomer is a unique shaped bone which has a V-shaped groove or a cavity or a depression in the bone itself. And one part of the sphenoidal rostrum is one part of this big bone, big butterfly shaped bone called the sphenoid. It fits into that V-shaped groove like that, like a wedge. It's sharp, and this groove is also sharply deep, and they both fit together, and the gap is bridged by this. We don't call it interosseous ligament there, but it is interosseous and it is ligamentous in nature. So there's a ridge, this groove in one bone and a sharp ridge in the other bone. Ridge and groove kind of joint was given the name shindylosis, and it is a fibrous kind of immovable joint. So these four names, please remember. Examples also you can remember. Revise it in your books. Next we come to cartilaginous joints, and these are slightly mobile because the material in between is hyaline cartilage. Now I didn't talk about cartilage as such and what kinds of cartilage there are. If you have come across it in your reading already, that's excellent. You're ahead of me, that's good. But for those who may not have read it, there are three types of cartilage: hyaline, elastic and fibrocartilage. Hyaline means glass-like, transparent. It is the most supple of the cartilages, and it is the major one, which is probably almost everywhere in your body. Especially remember when we said diaphysis, metaphysis, epiphysis. Epiphysis are covered by hyaline cartilage because all synovial joint cartilages, that is those which participate in mobile joints, have to be hyaline in nature. You can't have other kinds of cartilages usually participating in joints because the hyaline cartilage allows for the maximum movement which a synovial joint needs. Not so much movement perhaps, but allows for nourishment to happen only from synovial fluid. It's at the tip of a bone. It's not going to get any blood supply from inside, and the surface of it is bathed in a lake of synovial fluid. So how is it going to stay alive? So it has to be of a nature. The nature of the tissue has to be such that it can absorb nutrients from whatever fluid it is floating in without much support from the outside or from the periphery. So it has to do its job and stay alive with literally minimal support. So articular cartilage is almost always hyaline cartilage. If that hyaline cartilage is bridging between two bony surfaces, but there is no liquid or cavity or anything else available, then it is a semi-mobile joint, partially mobile, called a cartilaginous joint, and chondro is the root we use for anything to do with cartilage. So it's called a synchondrosis, right? Where the things which are coming together, syn is coming together or combining, are cartilaginous pieces. So for example, in that, the two types of varieties we describe are asymmetric and symmetric. Symmetric meaning that the cartilaginous apposition development is happening symmetrically on both sides or proceeding from two sides, whereas asymmetric is most of the activities proceeding from one side, maybe a little bit is happening from the other side in between the bones. So an endochondral bone on one side, another one on the other side, and the in between unossified part, we said no endochondral ossification, the center of ossification starts and bone laying down is proceeding in two or three or several directions. And when that is happening, the cartilage which was originally the model is being replaced by the bone, isn't it? So if it is happening from two directions and approaching each other, the plate in between we saw was called the epiphyseal plate when it is at the ends of the long bones. So that zone of cartilage which has not yet been replaced by bone, right, is a synchondrosis. Okay, that's one way of looking at it, especially when in a model where endochondral ossification is happening. So an endochondral bone on either side and a slab of hyaline cartilage in the middle is a classic architecture of a synchondrosis. Now when it is happening where there is a primary center growth happening, proceeding starting in diaphysis, going through metaphysis, coming towards epiphysis, and a secondary center has already started in the epiphysis and is growing distally towards the primary, there's a little bit of more activity here and a lot more activity happening here as far as the amount of cartilage is concerned. This secondary center, the bone laying down seems to be happening faster, so there is more movement. If you're looking at the advancing edge of bone, there seems to be more movement from the secondary center and comparatively less movement from the primary center. It does not matter. The point is they are asymmetric. They are not at the same pace. The bone is not being laid down at the same pace, or the shrinking of the in-between cartilage is not happening at the same pace on both sides. So that's all. Then we call it asymmetric. It's not very important from the point of any one bone, but as an understanding of a process, we have given it two varieties. Whereas if you have let's say here, this is between two cranial bones. There is a part of the occipital bone here which has your foramen magnum, which is called the basi-occiput, and there is another bone close there which is called the basi-sphenoid. So two different base of the skull bones are proceeding to get ossified. Okay, so this one's primary center is progressing and that one's primary center is progressing, and in between there is cartilaginous growth and transformation, but these parts of the bones are undergoing endochondral ossification, not intramembranous as with the flat bones of the skull. So the same bone occiput has a flat part which is undergoing intramembranous ossification, which means it's not bothering to lay down cartilage at all. Straight from membrane it is becoming bone. Whereas the base part, which has to accommodate the growing brain and spinal cord, is undergoing one cartilaginous phase which stays cartilage for quite some time. And right in front of it, another bone called sphenoid is doing the same thing. There is a basi-sphenoid and then there are wing-like plates of the sphenoid. So these plates are all flat bones and they are all undergoing membranous ossification. But the basi-sphenoid undergoes a chondrification stage. So the chondri stage of this and the chondri stage of that are both proceeding together. They are right there next to each other, and they are moving towards each other in a very symmetrical fashion. So basisphenoid ossification, basi-occiput ossification, they both are two different bones but approaching each other symmetrically, forming a cartilaginous joint between themselves. Okay, so that's a symmetric variety of a joint called a synchondrosis. And sorry, this is not O, this is C, S-Y-N-C. The fate of such a movement, definitely all synchondrosis will become a synostosis. That means together bone. This is together cartilage, this is together bone. So synostosis is what will happen to this phenomenon as age passes. So sooner or later the metaphysis and diaphysis will fuse and become a singular bone, that is a synostosis. Sooner or later, sometimes a little later, after the entire growth of the bone is over, growth of the human being is completed, young adultish probably, or late teen, mid-teen, some kind of age, the basi-occiput and the basisphenoid, though they are different bones altogether, will become a synostosis. The bone will fuse in such a way you won't even know what happened. You may see a fine white line or something if you cut the bone, where one and first and second bones were actually separated at one point of time. Then they were joined by a synchondrosis because of that hyaline cartilage in between, which had not yet got ossified. And finally, they became a synostosis. So no fiber, no cartilage, nothing. Only bone to bone are together. So the fate of a synchondrosis is it will become a synostosis almost always. In fact, always. If you follow any one bone right to its old age, or any one example of synchondrosis right to its old age. So this is one type of cartilaginous joint called synchondrosis. And then there is another type called a symphysis. Singular is S-I-S, plural is S-E-S. So a symphysis, the difference between synchondrosis and symphysis is that the in-between material is fibrocartilage, not hyaline cartilage, and it will also show certain age-related changes. Mostly it will not fuse, but it can maybe become a synostosis. The classic example of a synostosis resulting from a symphysis is the symphysis mentae, between two halves of your mandible. Both of them had a cartilaginous, both halves underwent a cartilaginous phase, and there was a synchondrosis at the beneath your mouth, right at the point of your chin for some time, but even well before you were born. That synchondrosis became a synostosis, or a solid one piece bone. You cannot make out that the two halves of your mandible were at one point jointed together here. Okay, so this is one classic example of a symphysis becoming a synostosis. But there are other classic examples which stay as symphysis all their lives, and the best one that you know is the symphysis pubis, between the left and right pubic bones in the pelvic girdle, right? And particularly in women, again, that's very important that they stay as symphysis and do not fuse, because the interpubic slight amount of movement which a cartilaginous joint provides is necessary for pregnancy and childbirth. So what is happening in cartilaginous joints? When you see a sectional view of the tissues, you see the symmetrical and asymmetrical synchondrosis that was in the previous picture. Then here, this is picture B, the intervertebral symphysis. Here it is a presacral one which he is showing. It's displaying age-related changes. So in the first decade of life, first 10 years of life, you're seeing one bone and you're seeing another bone. And in between you're seeing a fibrocartilage slab. So this classic example is the intervertebral disc. Okay, so what they're showing is this fibrocartilage in between. Annulus means ring. So you're looking at from outside. There is a ring-shaped fibrocartilages surrounding the end of one bone and the end of the other bone together. So between the two, they're held together by a ring of fibrocartilage. In the center of that, there is still a pulpy material called the nucleus pulposus, which is not yet fibrous in nature. It doesn't have fibers infiltrating it yet. And at the upper end of that slab, that whole slab is a fibrocartilage. At the upper surface of the slab and the lower surface of the slab, the joint between the fibrous piece and the bony piece is called a symphysis. So there's a bony piece, there is a cartilaginous piece, and then fiber has started. So that in between thing is called the symphysis. Later, there will be this is one vertebrum body, and this is another vertebrum body. The primary centers of ossification have yielded this much. Then some secondary centers of ossification are happening because an epiphysis has been raised. A ring, annular means ring shaped. It should be A-N-N, double N, wrong spelling. So a annular epiphysis is a ring shaped epiphysis happening at the lower edge of the upper bone and the upper edge of the lower bone, and that little cartilaginous bit, it's still not bone, is forming a synchondrosis, and later that will become a synostosis. Right, so you can see that projection has come. That's why it's called an epiphysis, because it's a projection from the main piece of the bone, and it changes the shape and architecture of that intervertebral disc to some extent. When is all this happening? In the young adulthood, 15 to 25 years, where the fibrocartilage is invading even this nucleus pulposus, which was just mushy matrix material, not yet impregnated with fibers. So when fibrocartilage is getting into that and laying down its architecture, at the same time a synchondrosis is happening with annular epiphysis, and later when you're having a mature vertebral column situation, a synostosis has already happened with the annular epiphysis, and the nucleus pulposus gets completely obliterated, and you have a full fibrocartilage slab in between. The gray bit, that is the joint between the intervertebral disc and the bone on either side, is a symphysis in nature. Okay, so this is part A, part B, part C. Part A and B actually don't have anything with each other. Part A and part C have a symphysis. Part B and part C have a symphysis on either side, at each and every intervertebral joint between the bodies of the vertebrae and their preceding and succeeding intervertebral discs. It's a little tricky. Maybe some of the terminology is a little difficult, but please read through 2-3 times, then it won't be so hard. So basically we looked at two types of cartilaginous joint: a synchondrosis, the fate of which is always a synostosis, and the material in between is always hyaline cartilage, and symphysis, where the material in between is always fibrocartilage. It has a progression with age, and there will be changes, and sometimes it may become a synostosis. Less common kinds of slightly movable joints are called interchondral or osteochondral junctions. There, the two things involved are not bones. One side is a bone and the other side is a cartilage, osteochondral. Or one side is a cartilage and the other side is also cartilage. That is interchondral. And the classic examples of this is what's happening in your rib cage, because the lower half of the front of your rib cage needs to expand in two directions, anterior-posteriorly as well as laterally, mediolaterally, to allow the capacity of the thoracic cavity to change whenever the diaphragm moves up and down for breathing, to allow the lungs to expand for every breath that you take. So between the body of the sternum and the rib, the ending of the rib bone part ends here itself, right? And it is covered by a pointed piece of cartilage, right, which is called a costal cartilage. Costa means rib, and the cartilage attached to it is called a costal cartilage. So this costal cartilage is going to reach all the way up and form a joint with the sternum, and this is a synovial joint. We are not looking at that today. We are looking at the joints between two adjacent pieces of cartilage which belong to adjacent ribs. Let's say rib 9 and rib 10. That's a wrong number, but let's say rib 7 and rib 8. Now rib 7 has its costal cartilage, rib 8 has its costal cartilage, and between the two there is an interchondral synovial joint. There is a liquid separating these two. Then you can have interchondral ligamentous joints such as a syndesmosis, which is what we had said, no, for like interosseous membranes. So we can have a syndesmosis between two pieces of adjacent cartilage, or you can have a synarthrosis, a costochondral synarthrosis with an adherent fibrocartilaginous plate. So here you have a bone and you have a cartilage. This has a periosteum, this has a perichondrium. When periosteum and perichondrium become continuous with each other, and there is a fibrocartilaginous bit in between continuity where they are, can you see, there is in between, when you see there is a little bit of a a fibrocartilaginous plate attaching the bone to the cartilage in between, then it is a costochondral synarthrosis. Synarthrosis means nothing but joint. Synarthrosis. So a costochondral joint with a fibrocartilaginous plate is the joint between any rib and its own costal cartilage. The direct continuation of rib with its costal cartilage. Whereas other types are possible in interchondral areas and osteochondral areas. Let's come to synovial joints. I am afraid I have very little time left, but I'll run through this. This I think you have studied right from 8th class onwards, so you just have to revise it in your book. Synovial joints essentially are mobile joints, and they are of various types depending on the shape of the articulating surfaces, the material, if any, which is available within the joints, if there is any, and the amount of work or the different types of movements which are possible between them. So essentially any synovial joint could be a simple one where the articulating surfaces have a simple relationship, geometrical relationship with each other, and there is only one bone meeting another bone with a single joint space. So most of our synovial joints are of this nature. We call it compound when there is more than two bones involved in the same synovial space, and the shape of the synovial space is comparatively a little more complicated. So we just using the word compound to say there are more than two bones involved. In a simple synovial joint, there are only two bony pieces, one part of one bone and another part of another bone, or another part of same bone. It doesn't matter. The point is that you have a singular articulation between two bony bits. In a compound one, you have more than one articulation. So you have one bone with bone A with B, so there's a AB articulation and there's a AC articulation. But it's a single joint space, so we call it a compound joint. And if there is any other material apart from bone, its articular cartilage and its synovial cavity, if there's any other thing, then we call it a complex joint, where, for example, here, can you see here, it's all blue. The blue is all the fluid in between contained in the white, which is the synovial membrane. Whereas here, the gray material has gotten into the joint. It's included, or it is part of the architecture of the joint between the two bones, and that's why it's called an articular disc. Articular disc, and this is therefore called a complex joint. See, the shape may look very similar to this, but some new element has been added which will change the dynamics, the mechanical dynamics of the joint, which is why this is called a complex kind of joint. So in synovial joints, there are many types. Plane joint, where the two articulating surfaces are completely flat, plane, and they can only slide on each other, and the sliding can take place in one axis or the other axis, right, A and B axis. And one classic example is the intervertebral joints, not the intervertebral disc one which we talked about earlier. Those are partially mobile, but these are completely mobile intervertebral joints. They are between the sides. There are intervertebral joints on the sides, not involving the bodies of the vertebra. Then there are hinge joints, where you have one more rounded surface fitting into one more concave surface. So one side is more convex or quite convex, and the other side is somewhat concave, and so there is a rolling motion in one axis only, working like the hinge of a door. The classic example is your elbow and your knee joints. Then you can have a pivot joint, where the articulation is such that one one bony end is completely almost spherical and fitting into a pocket, cup-like situation, not cup so much, but probably is able to roll or rotate in one pair of axis, and the receiving bone is able to fit it in that way. So this possibility is there. For example, the head of the radius is able to rotate within the annular ring provided at the elbow joint. So this is not part of the elbow joint, it's a separate articulation and it is of a pivot nature. Then you have the ellipsoid joint. Now this ellipsoid is the name of a shape, but what is happening here is one part of it, some amount of sliding is possible, the upper part in the anterior posterior and the medial lateral axis, but the other part, the lower part of it where the fitting is happening, is there is some amount of rolling, side to side curved movement possible, and that is your atlanto-occipital joint at the base of the skull. Then you have a saddle joint where you have a conversely curved surface on the ends of two different bones. So where there is concavity in bone A, there is convexity in bone B. Where there is convexity in bone A, there is concavity in bone B. So simply changing the shape of the articular surfaces will determine what movement gets possible or not, because they are hard structures. The shape itself will lock it into whether it can move in this one direction or not. So in this the moving part here, the proximal bone, for example, can roll in this direction and also in this direction, right? Or two pairs of movements become possible at a saddle joint. A saddle is what you put on a horse and sit on it, right? So between one leg and your pelvis and the other leg, there is a concavity. For the saddle, there is a convexity onto which the concavity of your legs sits. But when you look from front to back, the saddle has a concavity in which you are sitting, which is preventing you from falling forward or backward. So look at the shape of the saddle. From front to back it is concave, but from side to side it is convex. That shape, if a joint surface takes up, that is called a saddle joint. And the classic example is the first carpometacarpal joint of the upper limb. That is the base of the thumb joint. That allows you to do two pairs of movements. We will come to that later. Then, of course, everybody knows this one, the ball and socket joint, where you have a complete spheroid surface and a complete concavoid surface into which this fits. And the classic examples are shoulder and hip, where you can have three axes of movement. You can do flexion extension, you can do adduction abduction, and you can do medial and lateral rotation. And a combination of these 6 movements, which will allow you to swing your arm freely, also allows it to become a little more unstable when there is pressure applied. In the hip, it is more stable, less amount of freedom of movement, but all 3 degrees of movement are allowed. So this concept of freedom of movement is important. So a joint which has only 1 degree of freedom, a uniaxial joint, will allow only 1 pair of movements. A biaxial joint will allow 2 pairs of movements, and a ball and socket joint will allow 3 degrees of freedom, because 3 pairs of movements along 3 axes. If you put a mediolateral axis, that means it is a coronal axis, your humerus, head of the humerus, can swing in the shoulder from front to back. That means your elbow can come ahead of you or the elbow can swing behind you, right? So that is flexion extension, pair of movement. If the axis is anteroposterior, if you've pinned the shoulder through from front to back, then it can swing on that pin from side to side like that. So adduction, abduction. And if you pin it through the length of the humerus, right, then it can rotate on that length, medial rotation and lateral rotation. So this 3 degrees of freedom, the degree of freedom of a joint, is very important clinically when you're examining a patient who says my shoulder has become stiff, or I'm feeling weakness in doing a particular activity. You have to figure out whether the degrees of freedom of that joint are maintained or not, and if they are not, then what might have caused a problem? Which part of that joint is the one creating the difficulty? So that will depend on what happened, the nature of the trauma or the stress, and also what tissues are available there which might have been deranged. So you have to know what is there in the joint. Is there a fluid? Is there a membrane? Is there a cartilage? Right? Then you have to know the blood supplies of all those parts. You have to know the nature of the bone. You have to know the shape of the articulating surfaces, and then you have to figure out, okay, this is this much different from normal, and what do I have to do to restore full freedom of movement or full mobility at the joint for my patient. Okay, so this is the whole story of joints. I'll stop here today. Thank you. We will continue tomorrow at 11 o'clock. Please tell all your friends to be